Okay, good morning, everyone. So Yasminka already covered the basics on how to do the lung ultrasound and the DVTs. So I'm just gonna go quickly through that. Can everyone hear me? Yeah, perfect. The session is gonna be interactive with you. There's gonna be a mic coming around, so you'll be able to participate. And because I know that people don't like to put themselves forward, you will be able to participate in groups and just discuss with your colleagues on how to do it. My background, as I said, is that I'm an EM physician. I'm going to have my specialty exam in a few months. And thank you again for the invite back to your course. So first of all, my disclaimer, I'm really terrible at storing images. I haven't improved from last year when I was terrible. I got better with the ultrasound, but not at storing images. So the images are a mixture of my colleagues' images. Some of them are mine, and some of them are from POCUS libraries, but they are connected to the cases of patients that I had. Again, Yasminka perfectly covered why should you do the ultrasound. I think this is the most important part of what you need to know. Ultrasound could be a great adjunct, but if you think about the stethoscope, they said that it doesn't matter what the quality of the ultrasound, the olives are. It matters what's inside, between this. It's the same with the ultrasound. So you need to understand what you're seeing, and you need to understand how to interpret it. It's perfect for pediatric patients and adults. And for me, if I take a look at the lung, it's perfect for the undifferentiated dyspnea. So you take a look at all these things, so you can actually figure it out by ultrasound on what is more probable and what is less probable. But the lungs are not enough. Don't go forget about my heart. It's also really, really important to take into account that the heart is the part of the lung as well. And also, besides the heart, don't go forget about my IVC, okay? And the leg veins and the clinics, okay? Just to think about that the patient does not have just the lung. It has, the patient has everything, and you need to take everything into the account. Again, the legs as well, part of the exam. The how was covered by Yasminka as well. This is the blue protocol she was talking about. We have never met before. And I was really, really glad that as a radiologist, she put this up. So awesome. Please offer me a job here. You are so much nicer than our radiologists. So I just want to go through quickly through the blue protocol because it's really, really useful. Just to get some plastic sort of overview on what do you think about when you scan the patient, okay? And we don't just do it in the ICU, you do it in the ED as well. So when you take a look at the lungs here, you're all able to see the marker, right? Yeah. So you take a look at the lung sliding. Is it present or is it abolished? We always as emergency medicine physicians, it needs to be really simplified. It's yes or no question, or maybe-ish, okay? So yes, present. If it's present, I need to know, do I have B lines? If I have B lines, most probably pulmonary edema. If I have A lines, yeah, I will take a look at the veins, so the leg. If I see the DVT, then PE for the dyspnea here could be likely. If I had no DVT, then I take a look at the consolidations. If I see any consolidations, I might visualize them, as Yasminka mentioned, or if I see no consolidation, this would probably move me more towards the COPD exacerbation or pneumonia. Again, if it's abolished, I take a look at B lines, could again be pneumonia, or A lines. I'm looking for lung point, which I will show later on. And with no lung point, I will need further testing. So I will just need to be a bit more careful and take a look at the lungs a bit more in the depth. This is also shown, and I just want to tell you, B lines are also not all the same. For us, it was really useful in COVID times. This was the number, as Yasminka mentioned, the number of B lines made your sphincter a bit more constricted when you got this sort of patient. So if you got someone with like an 80% saturation, it was like, yeah, like maybe 4 or 5 B lines on like these 2, 3 intercostal spaces. If you had B lines up until here, you're like, oh, shit. So it's really, really important to understand that these sort of artifacts are going to guide what you're going to do with this sort of patient. Again, she mentioned how to do it in pediatrics and in adults. So you kind of all have the same like schematics. Because, for example, here, where am I going to look for air in the lungs? Higher or lower? Higher, because the air rises. Yeah. If I'm going to look for the water, it's going to go lower. Okay. So this is where I'm going to expect to see things. Of course, patients are like naughty little things, and they always try to trick you. So they might have like a pneumothorax here, and you're like, yeah, I'm going to look for the air here, and there's no air here, so I have no pneumothorax. And then you scan this area and like, shit. So I have a pneumothorax here. So like really, really take care that the patients have never read the medical books, and they were always going to try to trick you. Okay. So the leg part as well for the DVT, how you scan it. I like the way that Yasminka showed, but for me, if the patient is able to stand, the patient should stand. Of course, again, because the water goes down, the veins are becoming more dilated, and I will have like more specificity when I try to do the ultrasound techniques. One maybe mention or disclaimer about the D-dimer. Like you should order a D-dimer if you understand what the D-dimer means. And I really don't like when I get patients sent in with a D-dimer of 650 with no clinics. So I'm like, yeah, thank you very much for ruining my day. Because you really have to ask yourself why I do it. So for example, if I have a clinical suspicion of DVT, then I would go onwards on the D-dimer. Again, what are we going to do? Now we're going to cover the cases. I'm going to go into one case in depth. Can I get the microphone in the audience? Yeah, maybe we can start here in the second line and then just like I will not like push it on Yasminka first. Now it's the whole row. It's the whole row, okay? Like the only wrong answer for me would be, I'm gonna use the ultrasound to hit the patient with in the head with it, okay? This is the only wrong answer. No patient is gonna die. The ones that died already died, okay?
I don't touch it.
Okay, this is our recess room. The case for you, this is gonna be the in-depth case. So for you, you're like super lucky. You're gonna get that one. You're gonna get the case of 70-year-old male. He had at 2 days a progressive dyspnea. And he had like a substernal like chest pain, like not really like stenocardic, but it was not like radiating anywhere, and chest pain here. So the question, additionally, he had like no fever, no cough, no syncope. And for the past medical history, because you're able to look it up quickly, COPD, of course, heart failure, of course, post-MI, of course, because why the hell would you not have everything? What is your differential? What are you thinking about? There are no wrong answers, again. You can tell it in the microphone because the others are not able to hear it. What can this patient have? Louder. Yeah, you can discuss it inside the microphone. It's going to be easier. Can he have pneumonia? Yes. Can he have PE? Yes. Can he have a pulmonary edema?
Yes.
Can he have a myocardial infarction?
Yes.
Perfect. Can he have a pneumothorax? Yes.
Yes.
All the patients, again, are never read the medical books, okay? So even like no fever would not say, yeah, like he had no fever, he's not gonna have pneumonia. This is like really, really low specificity as well. Yeah, okay, of course I forgot he was diabetic as well. So this is a critically ill patient. Do we agree with this sort of things when he has like, he had a dyspnea, they put the saturation on, it was 70%. Do we agree this is a critically ill patient? Yeah. What do we do? Again, as emergency medicine physicians, ABCDE approach, okay? So if you look at A, Airway is clear. Okay? Nothing special there. On B, do we like the B? No. I mean, I like it because it's like critically ill patients, but like breathing 35 breaths per minute, having like the muscles working, like really, really working, wheezing on both sides. I was like, not really happy. Are we happy with C? No, as well, right? Tachycardic, hypotensive, there's a sinus tachycardia on the ECG. I'm going to show you the ECG. This was the ECG. Does anyone see maybe anything that's going to push you in the right direction? You just like think about this ECG. And then on D, like meh, nothing really specific. And on E, also nothing really specific. So my main problem, B and C, correct? What do we do with this patient? We said differential diagnosis really wide. Okay? Yeah? Agreed? So what are we going to do? We, like, besides the clinical work, apply oxygen, see whether I need to put in some fluids. We're going to take a look at the lungs, the heart, and the legs. Yeah? If I take a look at this patient's lungs, what do I see? My golden triplet there. What do you see?
We do not see like B lines, but we see mostly A lines. So.
Perfect. Okay. You take a look at the lung further. Do you like it? Like, of course, the central part is not the lung. We all agree, right? It's the liver. But for the lung part and the backside, do we see any effusion?
No.
Not really. Perfect. This is the heart. Do we like what the heart is doing?
Don't.
No, we don't. Why do we not like what the heart is doing?
It doesn't seem to contract well.
Is there anything else? Maybe I will show you another side of the heart.
We can see pericardial effusion.
Yeah, but this is more like fat here, so it's not that much of a pericardial effusion. I'm more worried about something else. The third row can help. You can pass the mic onwards so they get like inside. I'm gonna help you. This is the left side. This is the right side. Do we like the heart to be like that?
You have a dilated right
We don't.
ventricle.
Perfect. And if you take a look at this, we don't like it even further. Correct? Then we have his IVC, the third row. What do you think about this IVC? Yes, perfect. We take a look at his leg veins. What do you think about this? Let me just play it again. If it's going to play, if not, it's non compressible. Okay? So do you like this? No, perfect. So what are you thinking about now? Perfect. Perfect. So this is what we found. Okay? And we said, quite enough for the pulmonary embolism to be present. Again, if we use the B protocol, we would go here. Lung sliding, did we have it or no? Yes? Did we have B lines, A lines? What did we have?
A lines.
A lines. We look at the veins, then we found the DVT, PE likely. Perfect, right? Simple. So, again, lab and imaging. The D-dimer, is it going to be helpful? It's going to be as high as Snoop Dogg. Okay? So this is the true the imaging and the laboratory results for this patient. See the D-dimer really super high. Okay? The troponin as well because the heart is straining. And if you see the arterial blood gas, he had acidosis. He had some lactate. So this and chest ray, of course, not that specific as Yasminka mentioned before. And on CTA, when we did it, this is what we saw. And it's like, even I can see it, and I am no radiologist. Okay? So you see a settled thrombus. Yeah? So this is like how you approach the patient. So you go stepwise. Of course, this one afterwards, like he needed some oxygen. Then we discussed whether he needed like thrombolysis or are we just gonna go to the low molecular heparin? Like how much fluids do we get in? But this is not a part of our onwards discussion. We're gonna go to the fourth row now. Fourth and fifth row. Do you have the mics? Okay. So quick cases, just a bit of clinics and a bit of images, and you're gonna answer what you see. Okay, the mega showdown of ultrasound cases. Case, 80-year-old female, dyspnea from morning, perfect sats, perfect pulse, it's not perfect, and very high blood pressure. What do you expect to find?
Maybe a pneumonia.
Okay, perfect. What else? What do you think? Pneumonia, anything else? This is what you see? What do you see? I mean, the correct answer is the ultrasound image, but otherwise, like, what do you see on the ultrasound? A lines, B lines?
B lines.
B lines, perfect. Okay. This is what you see. Is there lung? Is my question. There is some lung here. Yeah? What's this?
Pleural effusion.
Pleural effusion, perfect. Here, I see the pleural effusion here as well. Yeah? Agreed? This is the heart. How is it working?
Bad.
Bad, perfect. How is it working from this side? Bad as well,
Also bad.
right? Okay, so again, if we go through this, A lines, B lines. So first of all, lung sliding was present, correct? A lines, B lines. B lines. Pulmonary edema, perfect. Yeah, so this was like acute pulmonary edema, and what was great about this patient here, we put her on non-invasive ventilation, and then when you have her on non-invasive ventilation, you can actually see the B lines disappearing in a couple of hours in the case of pulmonary edema, okay? So this is really great also to kind of see and follow through how you're working with. Next case, next row. The case, 50-year-old male, sharp pain on the right hemithorax and has trouble breathing. Perfect, let's say, vital signs. Yes, of course. What are you thinking about? Sharp pain on one side, low sats, tachycardic, a bit hypotensive.
Myocardial infarction.
Could be, yes. What else?
Pneumothorax.
Yeah, perfect. Perfect. So you always have to have a wide differential, yeah? Because then when you do some tests, you will be able to figure out what's gonna go on. How am I time-wise? Do I still have time? Perfect. You take a look. This was on the right side, the pain, yeah? On the left side, you saw this. If I move it like that, it's gonna move. Okay, this is what you see. Do you like what you see? Yeah? Louder, louder, into the mic. Do you like what you see? Yes. Okay, why?
Because we see the lung sliding.
Perfect. So you have no pneumothorax here. And again, never just assume because you don't see it in one intercostal space that there is no pneumothorax. You have to go like through all this side, through all of the lateral side and posterior side for the naughty patients as well. And the same on the right side as well. Yeah? This is the M mode. Do we like what we see on the M mode?
Yes.
Yes. What do we see? The seizure sign. Perfect. This is the right side. Do we like what we see?
No.
I mean, I do because I have the diagnosis now. But otherwise, we do not like what we see, right? Because we see no.
Seizure sign.
Yeah.
Or
What else? What do we see here? Because I said here, we only saw the lines and no lung moving. But what is this naughty thing here?
The lung point.
The lung point. Perfect. Do we have a pneumothorax? Yeah, perfect. And the M mode, just to confirm it. Again, the blue protocol, if you went through it like that, you would find pneumothorax. Next case, next line. 70-year-old male, dyspnea, and has a known pulmonal carcinoma. Again, the same, like everyone comes in with the same kind of vital signs because I work in like the red and orange triaged area. So everyone has like shitty vital signs. Like when they come in with like 94% of saturation, you're like, what are you doing in my department? This is what you see with this sort of patient. What do you see and what do you not like?
Pericardial effusion.
Mm-hmm. Do you like what the pericardial effusion is doing?
Actually, no.
No, perfect. Why not?
Because the pericardial effusion compresses the heart.
Yeah,
So
perfect. You have to know that the carcinoma patients have a pericardial diffusion quite often, but not that big. Okay? If it's small, then it's something that just needs to be followed up. This one needs a pericardiocentesis, not from me, because he's like, this is something that grew exponentially, but they need the fluid drained. Okay? This was it. This was another picture of something like that. Yeah, from another patient, of course. Also not that happy, right? Agreed?
agree.
Yeah, like the sphincter is doing, yeah? Perfect. Next case. Can you pass the mic? 55-year-old female. She had dyspnea, quite high fever, and a productive cough. No comorbidities whatsoever. She started in the fast track area 2 hours before that with a SATs of like 95%. And while she waited in the fast track area, she got worse. And she was transferred to me with this sort of SATs. This is what we saw. What do we see? Who has the mic? Can you lift your hand? Who has the mic? Where's the mic? Where's the mic? Perfect. Okay, what do you see? Like, again, there is no wrong answer. I mean, if you're gonna troll me and say I see an ultrasound image, sure. Come on, don't be afraid. Perfect. What do you see? Do you like what you see? Do you like what you're seeing?
No.
No. Perfect. What are you seeing here? This is the thing that Yasminka was talking about, the third thing. The direct visualization thing that you need to see. So, lung consolidation, okay? Here, on the other side, what do we see? The same thing that Yasminka showed, okay? Again, this is not the liver, it's the lung, yeah? And it has like the same consistency because in the late part of pneumonia, you get the hepatization. That's why it looks like that. I never got what the hepatization meant until I used ultrasound. Because like, oh, this is quite the same as the liver, okay? And it's where the liver is not supposed to be. Okay, perfect. Next, can you pass the mic? Case, it's the, how much time do you have? Yeah, okay. 65-year-old female. This was 5-6 days ago when I was on oncology wards. She was admitted to oncology. She had memory carcinoma and metastasis, like a bit, I think, in the head, some of them in the bones as well. But she was admitted because they said like, yeah, she was like a bit sleepy. But then they like said, oh, can you come please help me? Because she has like a low SATs. She was not dyspnoic at all. And she had like a low blood pressure. So like the sleepy part could be because of this. Yeah, agreed? What are you thinking about? What's your differential here? The 7th row. What's your differential? There is no wrong answer. We have put up some differentials before. Could it be pneumonia? Could it be? Yes, it could be. Could it be myocardial infarction? Yes. Could it be a PE? Yes. Okay. And I'm just going to show you one part. this was on because when you take a look at her, the lungs, like, man, nothing really like much to hear there, like a bit of crackles just in the lower part. The ECG, nothing really special there, but her left leg was a bit swollen. The right side was this. Do we like what we are seeing? Yeah, because it's winking at us. Yeah? Okay. We go then lower because, as Jasminka said, we need to cover different parts. When we go, again, this is a bit more of the Mickey Mouse sign. Yeah? We like what we see. Yeah? On the left side, this is what I saw on the left side. Do we like what we are seeing? The thing that's winking at you, it's not the vein. It's the artery, okay? So if you take a look at this lower part, I'm going to go back to beginning. This is the vein. And you have a direct visualization of thrombus. I have never seen a thrombus as clear as this one. I was like, fuck, this is quite huge. And we did the CTPA because of pneumonia as well, because of pulmonary embolism. She had pulmonary embolism as well. And because, do you know the Hickham's Dickham? No? Have you ever heard of it? It's like, first of all, when you treat a patient, you think about Occam's razor. So high probability of something, you do some tests, and then you confirm this. But Hickham's Dickham says the patient can have as many diagnoses as he damn well pleases. And she also had pneumonia, okay? So it's like, don't just like stick to one part, but like be thorough. Next, this is also maybe just to show you one of the other non-compressible veins as well. Do you agree? Non-compressible? Yeah, quite clear, right? And with this, I would like to conclude my presentation and have the floor open to questions. This is my department where I work at, like really bright future for the department as well. This is the people that we work at, of course, the boss lying down. And this is my contact info on Twitter. If you liked my presentation, my name is Aleks Šuštar. If you didn't like it, it was Liz Truss. So thank you for your attention. If you have any questions, I'm going to be here for you. Thank you.
Yeah, well, thank you very much for your interactive presentation. It was very entertaining, and I hope that you've learned something. Does anybody of you have a question?
Can you get the mic?
So for the assessment of the leg, you said if the patient is able to stand, he should stand. Do you have a preferred position for the assessment of the lung? Should it be supine or sitting up?
Perfect. So for the legs, if they're able to stand, I would put them to stand. The problem is that most of them who come in have like one of the Wells criteria that Jasminka mentioned was like prolonged immobilization. And a lot of them are like lying down from the like previous non-mobile status because they are like really old and like lying down. So of course, I'm not going to say to the 90-year-old bedridden granny, can you please get up for me so I can do the ultrasound? Of course not. But if the patient is like 50 years old and is able to stand, I would put them stand up because then you are able to not move them around to assess the popliteal as well. You have the veins that are really filled and it's much easier to see. You can actually see like the clear difference if you like try to do it afterwards when you're lying down. And then when you stand up and you do it on the same person, the same exam, it's going to be much better when they stand up. Of course, one very important thing, the DVT can not only occur in the legs, okay? It can also occur in the arms. But there's like no clear protocol and like something easy to visualize. And it's also like much rarer to occur in the arm as well. So just have a think about that. For the lung ultrasound, I will have them in a 45 kind of degree as well, because usually they are like really in respiratory distress. usually I have them like in either non-invasive ventilation or like a really high oxygen feature for that. Like for something like that, I wouldn't like make them stand because I could make them stand, but then I would have to move them towards the accidents part of the emergency medicine department. But for me, like having this sort of thing, and maybe like if you want to visualize something, you can just like have them like lie down. Even when they are intubated, when you intubate them, it's perfect to just like have them like lie down like that. If you have them like for pneumothorax, again, if you put them like on a 45 degrees, you're gonna have air here, so it's gonna be easier maybe to visualize. Except if they are like naughty and have pneumothoraces on other sides as well, of the body as well. Does this answer your question?
No other questions, I guess. I have a question. Is there a possibility to differentiate between a hematothorax and a pleural effusion in sonography?
There is a possibility, but for me, like what's important for first of all, is to see whether there is air or whether there is fluid inside. Sometimes, like you could have like a the different echogenicity of the fluid inside. Maybe Yasminka will be able to say that I'm not lying. Yeah, okay. But the problem is that even if you have like let's say an effusion because of pneumonia, when you have pus inside, it can also look like really similar to like a hemothorax sort of thing. So like for that, I would say like I'm not sure. I see the fluid here. There's like plenty of fluid, and I would discuss it with my radiologist. Like either do you come to the bedside and you determine because you're better at this than me, or we go to the CT and then according to the house fields, you're kind of able to differentiate whether this is blood or whether this is like pus or whether this is sort of like active bleeding. So for the management of patients like that, I would like consult radiology. Would you do the same? Yeah.
Okay, thank you very much.